audio, so he may say whatever he likes. Okay, this is supposed to be a different session, and so we really hope for it to be successful, because instead of, the standard and usual papers, we want really to go straight to the key points of this surgery, which is struggling in becoming widespread, although it is recognized. Can you? He was asking about the translation. Okay, so despite the fact that it has already been, by now being recognized, it's struggling to become a common surgery. So the advantages of DALK are known to everybody. So we are not going to change the endothelium. So we avoid and prevent endothelium rejection. So we reduce the loss of endothelial cells. This translates into longer survival. And we also get a better scarring, so a greater corneal resistance. And this is thanks to the papers and works by Armin. And then we have also lower risk of glaucoma, cataract infections, and even more rare complications. And we also have more available tissues, because tissues that might be scrapped and wasted for perforating instead may be used for a DALK. We know that the survival rate in DALK is quite good, and it's above 99% with a 10 years follow-up, and the failure rate is very, very low. Very rarely does it happen, and it's highly circumscribed. Very well. As I was saying, failures occur in the first 2 years, as in all keratoplasty surgeries, including perforating ones, because we have problems of innervation of the new tissue, that the tissue is less able to defend itself. So the only failures that we observe in DALK surgeries usually are early failures. But once 2 years has elapsed, usually the tissues is well adhered and can defend itself. So there is a long-term survival. So it is no longer time-dependent, as it happens in the PK, which, as the years go by, the number of corpses goes up. However, this surgery, as I said at the beginning, struggles in becoming widespread, because this is reported from the U.S., and you may see that in North America, 20,000 PKs are still being performed versus only 1,000 DALK procedures. And so this might suggest that we are really in love of this procedure, because you know that DALK has been strongly supported in Italy. But let me now go against this idea, because the PK trend in the US goes up, the EK, sorry, and but lamellar stromal keratoplasty actually is at a standstill. So DALK continues to be considered in the world a difficult surgery. That's why we decided to organize this session differently this year. That is to say, to go to the key points and the most difficult points in this procedure to try and encourage this transition, which is struggling to take place. And actually, for DALK, the problem is, as usual, the survival. There isn't any better opportunity of having with us such renowned and distinguished world-scale surgeons, and they are deservedly so, because they are great surgeons. So this is the best opportunity to consider these issues. So let me introduce you. Sandro Cascarelli from Brazil, Dr. Fogla from India, Jose Guel from Spain, Tarek Katamish from Egypt, Barry Lee from the States, and Donald Tan from Singapore. What are the most widespread and common techniques? It's difficult to summarize here, but however, let's say, the techniques which are more widely recognized are the ones that I've just mentioned. But if you wanted to mention them all, probably I would have needed as many as 10 slides. Certainly, a very good technique is the peeling off. And let me tell you that today we have here with us
l'autore, colui che ha
the author, so the surgeon who described this technique for the first time, Dr. Malbrand, and we all owe to him because this is the first example of a deep lamellar keratoplasty that really worked. We are talking about the pre-decimate bulk, but when we go deeply inside and the tissue detaches, we are sure, we are safe that we have reached a deep enough layer. So in the post-op period, you see that there is a very uniform and regular residual bed because everything actually was detached, which is at 10 or maximum 20 microns, which we know that will allow an optimal visual recovery. So this is a technique that wasn't extremely successful. So recently it has been reproposed, and we have a surgeon who really strongly encouraged it, our friend Raish Fogla. He even designed some specific instruments to do it.
Microphone? Yeah, there are two microphones here. Okay. Is it working? Yes.
Yeah. Working.
So here, your video, please.
Well, in cases where the decimus membrane is involved in any kind of pathology, especially scarring process, air injection can have undesirable outcomes. So we resort to doing a manual dissection. So we have designed a stromal pocket forceps with which we can make a pocket in the periphery. And then as we peel off, there's a semi-sharp instrument, which is a dissector, which is semicircular. With that, you can break the fibers, and you can achieve, like, you can go up to something around 50 to 60 microns close to the decimet, and that gives equally good result as what you get with the big purple.
Yes, thank you. Just to be more clear, when do you use this technique?
I use this technique when I don't want to inject air. So this will be like post-eye drops, or if I do an anterior segment OCT and I find that the decimets is involved, the scarring process is involving the decimets. So in such situations, or sometimes when the initial part of the surgery I encounter a perforation, and then I cannot inject air anymore, so then I need to convert to a manual technique, so then you can resort to doing this.
So in other words, you are using this technique to do layer by layer?
Yeah, it's not exactly layer by layer, so we do a deep trephination.
Yeah. Manual dissection,
and we remove the first 50% of the thickness, and then we start making the pocket at about 85 to 90% depth, and then we just peel off the whole thing as one layer. So it's not like multiple layers, so basically the surgery completed in 2-layer dissection.
Yeah. So I don't let you speak about this subject because we will go back to this subject later, so please wait. About the visual recovery, I want to say to you that DDALC, that means big bubble or Visco dissection, has a recovery of the vision that is very similar to PK. But PDDALC is comparable with DDALC if you follow some rules. And the rules are that you need to wait a little bit more because the recovery is a little bit slower. The other rule is that the residual bed needs to have 3 conditions. Less than 80 micron deep significa che il...
It means that the residual bed must be thinner than 80 microns. It must be uniform in terms of thickness, so uniform thickness and a smooth surface. These rules, I mean, they date back to a long time ago, but they have recently been confirmed. Actually, these were the rules set in 1971 by José Baraquer, and we have Rafael here with us. He attends our conference, and we're proud, really proud, to have him here. The other technique that it's worth mentioning is hydrodissection. Hydrodissection is a technique put forward by Sicsso in 1997. He also was a recipient of a Sicsso medal lecture, and by the way, there will be 2 medal lectures after this session. It allows for an excellent hydrodissection or dissection. Of course, now with the big bubble, it is less and less indicated, and then the divide and conquer dissection technique by Tsubota, you all know it. And another technique has also changed. The dark era, the technique by Messo, put forward by Mellors in 2000, suggesting the use of a viscoelastic to detach the decimate membrane from the stroma, creating a visco bubble. But we will discuss about this topic later on more in depth. And last, in 2002, the big bubble dissection technique was described. This is a very popular technique by Mohamed Anwar, and Mohamed Anwar will be the recipient of our medal lecture next year. He will be with us next year. He suggested this technique. It is the most widespread in the world nowadays. The needle big bubble dissection was sort of modified in the late 2000s. The needle is scary, as a matter of fact. When you use the needle to go deep into the stroma, you might perforate. In order to have a big bubble, you have to go very deep. And a needle might be scary, as a matter of fact. So you can't, a cannula was used as a replacement, and the cannula that we use is a modified cannula, but also other proposals came by Tan and Fogla. Cannulas came in. This is a cannula. This is the one I use. There are many other cannulas by Tan, by Fogla, and many more. And this is a cannula big bubble technique. The advantage is that you can really go deep. And the last technique that deserves to be mentioned is recommended when the big bubble fails. If there is no big bubble, even if we are very deep, like in this case, even if we are using a cannula, the big bubble doesn't form, and we know it because we do our bubble test, and air in the anterior chamber, instead of staying in the periphery, goes to the center. It means there is no big bubble. If we have injected air into depth, and we will speak about this, then the reason is that the adhesion of the decimate to stroma is very strong, and air cannot detach it, while a viscoelastic, whose density is higher, can do the job, like in this case. And this is the visco bubble technique. I've recapped what we do in DOC to get to the core of the discussions during the roundtable. These are some questions that always come out during the courses on the DOC. We'll want to go through each of them. One of the first question is, which is your standard DOC technique in keratoconus? And this is, you see, a list of the answers that we have already collected. The whole faculty you see in front of you today is in favor of a big bubble. But Guel wrote big bubble or visco dissection. So, Dr. Guel, it's for you.
Big bubble or visco dissection. why sometimes you do big bubble, why you do visco dissection. Microphone to... Was the microphone? Yes.
Oh, yeah. Thank you. Well, in fact, I was a little bit...
You have a video. Do you want to send the video?
You can send the video, but
Okay.
basically what I mean is not... they are not two different techniques. This is the same technique. It's Visco bubble. That's the bubble. Well, you asked me to send a video where we cannot create the Visco bubble, which is my standard technique. And then if I could not get the Visco bubble, then I take out tissue layer by layer until now I get the Visco bubble. So what I meant with my response was that I use big bubble, but always with Visco.
So you mean that you put some air and then try visco bubble?
No.
Or you start with big bubble?
I'm doing Visco bubble.
Oh, so your choice is not big bubble, it's visco bubble.
Which is Visco big bubble.
Visco big bubble. Okay. Okay. I'm sorry?
Cohesive.
Cohesive. Why cohesive, please? Why?
Because it's more or less the same as when you're doing anterior segment surgery.
Yeah.
So the density is higher, so the capability to dissect is higher than when you're using dispersive. So dispersive is useful for protecting the endothelium, for protecting the anterior cornea, but not for dissecting. So, but you don't need high viscosity. I think that with a standard cohesive is okay.
Another advantage is that it's easier to remove before you put the donor, right?
Well, of course.
Yeah.
But on the other hand, if you leave some dispersive, is dangerous because it will remain there.
Yeah.
If you, cohesive. If you leave some dispersive, it's like water.
Yeah,
It
I know.
will disappear. It takes longer, so you will have a double chamber swallow, but a double chamber for a while. But finally, it will leave. But I never use anyway dispersive.
Okay.
So
let's move to another question. The other question was, are you still using a needle or did you move to cannula? And this question, we get this answer. So mostly of surgeons are using cannula, but Jose Guel and William Berry Lee, they use needle. Is it correct? Can you spend a few words about this?
I think there's a lot of great cannulas out there, but what I learned the technique from Dr. Anwar in 2006, and I've just done so many with the needle. I haven't felt the need to convert.
No, just because you are used to you.
Right, used to using it.
Yeah. And you, Jose?
well, it's just to save one step, and also because I'm used to. So to introduce the cannula, I need first the needle.
Yeah.
Or something to open a small window to
Well, a
introduce
smooth
the...
spatula is not a needle.
Sì, però necesitas due strumenti.
Yeah,
Se
yeah,
tu utilizza
I have to. Se u-
So let me say that recently we published this paper comparing 250 cases done with needle and 250 cases done with cannula. And i nostri risultati, I speak Italian for much more comfortable. In questo tra due
In this comparative study between two groups, one with a needle and the other one with a cannula, we have observed that D-DALKs, and this term probably includes incorrectly big bubble type 1 and type 2. But the term D-DALK actually has been suggested previously before the big bubble 1 and 2 being clarified by Dewar. So we have here included both of them, type 1 and type 2. So the D-Dalk were 78%, whereas with the cannula, 94% have been performed. So we've moved to cannula, apparently, because with the cannula, we can use the decimeter more frequently. So we have two groups of numbers. First group includes D-Dalk performed with only air. So from 61, we moved to 82%. In the second group, we have the a Visco bubble, it is to say, where the Visco dissection is used, because with air, we couldn't separate the decimeter from the stroma. And so a further 70% and 12% was added. So as a total, we get a further 14-60% is added. So this might be classified as a D-Dalk. Obviously, when you go for a D-Dalk, we also get another finding, which, despite the fact that we have made a correlation to surgery, we should remember that the first group belonged to our first 250 cases, whereas the second group actually included our second 250 cases. So in the first group, there were 6.5% ruptures, whereas in the second group, 2.5% of cases. But in both groups, we never had to convert, and we could repair the ruptures or breakdowns. So what are the advantages of a cannula? According to us, the main advantage is that the number of D-Dalk increases, and since we have a D-Dalk, we can have a faster recovery of the visual acuity, and the surgical time is reduced. There is less stress of the surgeon, which is important, because there are only a few D-Dalk surgeons around, so we have to survive and to stay in good health. So we are sure that we have made a very good surgery, because if we get a big bubble, it means that we've gone deep enough and the number of breakdowns is more limited. But we have another supporter of the needle big bubble, which is who is Barry Lee. These are his videos.
You have two videos? Please say something.
Yeah, as you just see here, as Jose mentioned, it just saves you an extra step to put the needle in. And certainly, I think if you're just learning this technique, as Enzo's paper showed, the cannula, I think, would be a safer way to learn. I think if you've done a lot of these, it saves me a step. It makes me a little bit more efficient to just do the needle. And as I said, I haven't really seen a reason to change to the cannula for my technique.
So the other question, l'altra domanda è...
The other question is, big B injection is to be done before or after cornea debulking? Both techniques are mentioned, and these are the answers. Fogla, Guel, and Tan do the big bubble air injection after debulking, which makes sense because we are already cutting the cornea. After debulking, we can be deeper. But Donald Tan, my comment on this video, he has already done debulking.
Your video?
Yes, so I've already done the debulking. The reason I do this is several reasons. Firstly, if you're trying to get very deep, you've already thinned the cornea down. So this is just a needle pinprick. It just goes in very little bit before you have the cannula. And you're able to have better visualization, and your cannula is deeper, and it's also parallel to right at the center. And so I tend to get a central bubble. And so I don't have to rely on my trephination depth. And so you can see that it makes it a lot more predictable to remove one layer first. The other reason is that anterior removal is very good training. My fellows learn to do this, so they learn the manual layer by layer dissection.
Yeah.
And it's quite safe because you're only debulking 50%. Now, if you then perforate, for example, or you don't get the bubble, then you've already learned that layer by layer technique, and then you can switch to the
Il microfono qui non fa bene. Se ce lo...
And this microphone doesn't work, so maybe it is worth changing it.
About debulking, please go. Is Reish?
So I like to actually potentially do both of these. So I like to do the needle big bubble first, but if you don't get a big bubble, you have the second chance to do the debulking step. And so I can use that as a backup. So I'll have two chances to get the big bubble. If I don't get it first before the debulking, you can do a second debulking and do the needle or cannula second. So it gives you 2 times to get a big bubble. If you fail, that's why I like to do the
That's very
debulking second.
interesting.
Isn't it easy just to get it in one go?
Gives me 2 chances.
I know, but you're doing it twice, right? You just said it.
Well, no, if I don't get it
I think
before debulking.
Yeah, so before we were the first, I think, many years ago to describe removing the anterior layer, and we looked at our data, and in fact, quite often you don't get the bubble on your first try if you are from the trephination margin. And that's because you're scared to go too deep, and if you're in the mid-stroma, you just get stromal air. So once we switch to just removing one layer, straight away you're so much deeper. The percentage of time you get the bubble at the first go is higher. And we found that with all our fellows. So that's our rationale, I guess.
So, Reish, do you want to say something?
Well, if you take a donor tissue and you create a big bubble and see from the endothelial side, you will see how much the decimus is stretched. So if you create a big bubble and the pressure becomes very high, so the next step you do is you do a paracentesis to normalize the pressure. And at that point of time, your entire decimus is plastered against the lens and the iris. And then if you spend time to cut the anterior lamella with the lateral movement, you may be actually killing endothelial cells. Whereas if you debulk first, and then you create the big bubble, and you make a paracentesis, then the next step you do is just to deflate the bubble, so your decimus falls back in position. So thereby, the endothelial cell loss can be minimized. And the second point is that once you create the big bubble, make a paracentesis, and then you start doing your debulking, you may accidentally enter into the space, and then you cannot locate the space where you actually entered. So now you have your decimus that's plastered against that, and you don't know where exactly is the opening, and then you have to resort to doing a manual technique. So I think from a teaching point of view as well, one is that you remove the anterior stroma, so the incidence of stromal emphysema is minimized because your cannula is going to go deeper, so you don't get that intense whitening that you see. So, once you get your cannula at the deeper level, your chance of formation of big bubble is more. The only situation where you would like to avoid debulking is advanced keratoconus where the apex is very thin, and if you debulk, sometimes at the apex you will actually reach very close to the decimus, and then if you put your cannula and you try to inject air, the air starts coming out anteriorly. So in those cases, maybe I would prefer not to debulk, but most of the other cases I do debulk.
So you said something that is really interesting. I should move to the bulk first. Only one problem. I'm afraid about the maneuver Donald did with the needle goes inside and then with the cannula.
Yeah,
so probably we can make the tunnel first,
yes,
and then the bulk, and then do the, yeah, that can be interesting.
There is another advantage because most of the cases that we're seeing on the screen are keratoconus because it's one of the more commonest indications. But in those cases where you have significant opacities, then the advantage of doing this debulking first is why I started doing that. It's because then you have a much better visualization. And that's the same reason by what I prefer to use Visco, because despite that you might fail in creating the bubble with the Visco, still visualization is quite good with the Visco and the stroma, so you can follow dissection. So visualization is much better, especially if there are opacities.
And so the other thing about removing the front layer now, and which is very useful, if you can, have a intraoperative ultrasound pachymeter, because not OCT, that's too expensive, right? Well, you could, but you know the standard you can get a pachymeter. Some of them are now handheld, and so when you remove one layer, you can measure that.
Pachymeter, how can you use the endol piece that is not sterilized?
Oh, it's not a big problem, because basically if you put a disposable glove, you hold it, and then you use alcohol, right? And you're going to be on the stroma, which you're going to remove anyway. So that's our routine. You know, if you debulk routinely like we do, and sometimes you remove one layer, and it's 300 microns, right? Sometimes you don't get the bubble. If you get 200, it's just perfect. You know, so it's a useful trick to, if you have it, and it's not inexpensive.
And remember that you can have 2 or 3 tips, because the most expensive part is the unit, not the tip. And you can sterilize on the gas. That's what we do. So you cannot.
Not easy.
If you have 4 or 5
to send
cases.
15 days before.
No, 15 days, not 24 hours.
Here.
I know.
Here.
Okay.
In Italy.
Okay.
I know. Well, let's move from some other subjects. We have many subjects to discuss. Another key point is how do you open your big bubble? So the original technique described from the Mohammed Anwar was with a knife cutting the stroma and destroying our heart. So 2 effects. So let's see what Beverly suggests. Look the eye and the heart, both. So please, make the comment.
So I like the heart comment, because it's beating at this point very fast. I like the viscoelastic first, and then I mark my, it's a 15-degree blade, and I go in through the viscoelastic so that the air release is slower. Otherwise, it can release very fast and easier to perforate. So I like the viscoelastic to slow this process down. And then again, angling the blade so it's not going straight into the endothelium, angling it so as the air releases, the tissue comes slower before you come out.
So let me show you this other technique. We all have to say thank you to Mark Terry that first suggested to use a viscoelastic before opening the bubble. Well, I took this idea and I changed the knife. Scusate, ho preso questa idea.
I took this idea and I changed the knife. I now use the cataract knife. Why? Why did I decide to do this? Because maybe schematically we can follow better. You see the air bubble as a pressure upward. If we enter the air bubble from below with a cataract knife, exactly as when we do the tunnel for cataract, even if there is viscoelastic, the possibility of entering the big bubble and without releasing too much air, only little air, because the tunnel prevents the air from coming out all at the same time, especially if it is covered with viscoelastic. So the bubble shrinks a little bit, which helps, but doesn't deflate totally. And at that point, with the cannula, we can enter the bubble, and we can replace the air with viscoelastic, as we are doing here. So slowly but surely, we have the air come out while we turn a big bubble into a visco bubble. So then we have a visco bubble that can be easily opened with forceps, with scissors. Well, now let me show you a video. You see, the blade, the knife enters. We don't have all air coming out. Air is slowly released we cover with viscoelastic, we enter viscoelastic. It's easier to open the bubble then.
We have time
This
to
is
discuss.
this is one of the advantages of using Visco big bubble.
Yeah.
So if you already have Visco, you do not need to.
Oh, I know. The problem of visco dissection, I say why I don't use visco dissection like first choice. Because if visco dissection fail, sometimes you have visco inside in the stroma, and when you do layer by layer, it's a little bit more difficult to go very deep, and going deep and deep and deep and deep, sometimes you perforate. So I want to have a visco bubble, but I don't want to try visco dissection. That's my position, but you know that every position is very good. It's important that we cannot do PK for a stromal disease. This is the key point. Do you agree, Mark? Never convert. Okay. Okay, please.
One of the other points for deflating is that I would release aqueous from the side port and try to make the eye as soft as possible. So what happens is your peripheral part of the cornea becomes soft, whereas the central part, where is the big bubble, it still remains tense. And I would loosen the eye speculum to reduce the amount of upthrust that you have.
Yeah.
And then if you go ahead, put viscoelastic and deflate the bubble, you will realize that your posterior layer will gradually come up. It won't come up as a snap.
Yeah.
So without releasing aqueous, if you try to do that, it snaps up very fast. And if you're not quick enough to remove your knife, you end up perforating.
Yeah.
And the entry point, I always, because the cornea turns white, so I always use a marking pen
Yeah.
to highlight the area where you're going to perforate, because often for a beginning surgeon, they tend to make an opening that's very small. And then against the white background, they are not able to figure out where exactly they made the entry. So if you increase the contrast by marking the surface with a marking pen, your point of entry can be seen very well. And then you can go and inject viscoelastic to try and open up the space to be able to put in a scissors and enlarge the opening.
Okay. Any other comment? Fatemi ricordare che
Let me remind you of the fact that there's a Sicsso party tonight. There is only one way not to be confused. We have 500 attendants, so you should really check for your bus and bring your ticket with you. Bring it with you, because there will be 500 guests at the party. So all those who are joining us at the party, please make sure you are on the right bus or on the right coach, and bring your ticket with you, please. So another question is, what do you do when big bubble or visco bubble fails? Well, big bubble fails. Well, actually, these are the answers. Air visco bubble is my technique. I mean, and Fogler technique. Coscarelli repeats air injections. Katamesh repeats air injections, second, the third, and the fourth, and the 10th time. Am I right? And
Barry Lee, José Guel e Donald Tan immediatamente.
well, and Donald Tan, they immediately moved to manual dissection. So there is no consensus. Anyway, switching to manual dissection seems to prevail. No one converts to PK. And here we have a schematic representation on the visco bubble. Mr. Orkun Mutfroglu suggests a model to explain how, if a big bubble fails, a visco bubble can do the job. He says that there are many bubbles, small bubbles, that form. They are not able to detach the decimet from the stroma, so air follows another way. Instead of detaching the decimets, viscoelastic has a higher density, so it is easier to detach the decimate. A small air bubble can turn into a big visco bubble, and in the end, you see these are his histological examination. This is a study that was done on spare bank corneas, and here you see Tarek Tamesh, who is obstinate air injector.
When you fail to get the bubble from the first injection, don't lose hope that you will get the bubble. So I always try injection at the same site again with a large amount of air. But if it does fail also, I go and do another deeper plane. And as you see, still the tension is soft, and you cannot have a bubble with a soft tension. Go further with a deep dissection and another fourth injection, and you will see now the sudden appearance of the bubble after the fourth injection. And sometimes you have the bubble after as many as 5 to 6 injections. So I don't convert or do lamellar dissection, except I do at least too many times of injection.
Great, very good video. Do you have the same approach with women?
Yeah.
Okay, let's move to another question that is really very interesting. How do you choose trephination sites? Una delle domande più frequenti è:
One of the most frequent questions is, do we change diameter? Same size donor recipient? Well, look at the answers. There is no consensus. Some say that they decide on a case-by-case basis. Coscarelli and Katamesh never change diameter size, and William Barely always chooses an oversized donor. Look at this other table. It recaps. You see, in high myopias, I do an undersized donor because I have an effect on the spherical equivalent, especially if I'm in front of a phakic patient whose spherical equivalent is high in one eye. So if there is no tear, I do an undersized donor by 0.25. And DONOR-10 has my same approach, while Coscarelli always, and Katamish, they always choose the same size.
Barry, why you do oversight?
I oversize 0.25. I use a Hannah Trephine. And I just feel like some of the patients, when I same size or even undersized, you get a stretch on the endothelium. I feel like it get less chance of getting stress lines or stretch marks on the endothelium when I oversize.
Yeah, yeah. Any comment about this?
No, qui è sbagliato. I use generally 0.25 bigger the size.
Oversized.
Yes.
Oh.
Never, because you can have a flat corner if you put the same size. And the Delling is very common.
Okay.
Can I speak in Italian too?
Yeah, sure.
Oh, sure.
Coscarelli is an Italian family name.
Yeah, my father was Italian.
Italian. Oh.
Yeah. From Napoli.
From Napoli.
Yeah. Scusate il mio italiano.
I apologize for my Italian, but I want to speak Italian since I'm in Italy. And if I don't speak Italian here, I mean, it wouldn't be, I wouldn't honor my family name. My family name is Coscarelli. Well, I use a 0.25 0.25 oversized. I mean, oversized 0.25. And in other cases, you can also do 0.50, always oversized. Never the same size. And Sandro, when you do this surgery, do you ever find 3-4 diopters of myopia postoperatively? No. 0.25. Well, no myopia. 0.25, never myopia. Okay, let's move to the following question, which is often asked at courses. When and where? Paracentesis, the paracentesis. When and where should this be done? Well, the answers, before big bubble and visco dissection, after big bubble and visco bubble, after big bubble, after big bubble and before visco dissection. Well, you see, no consensus. 4 are in favor of after BB and before visco bubble. I think that we are all
Really?
That what I presume that yes.
I received your answer.
No. But I mean that I think that once we have the bubble,
Yeah,
so once we are planning to open the bubble,
yeah,
doesn't matter how many
yeah.
steps you had before, we all agree and that we need to have the eye soft.
Oh, yes. No,
And-
the question is, do you do the paracentesis before or after the big bubble? Yeah.
Well, okay.
But there is consensus here.
I think there is consensus.
I think that nobody says that they are going to do a paracentesis before they try the big bubble.
Yeah.
So that's the main consensus.
Can you explain why to all the auditorium?
Really, because when you do a paracentesis and it's in the corneal periphery, you are creating a hole
Yeah.
in Descemet's membrane.
Yeah.
Sometimes when you inject your big bubble, you get a very fast bubble
Yeah.
or a type 2 bubble. And a type 2 bubble goes very fast, it's uncontrollable, and goes right up to the limbus. And then you will hear pop, and you will have a macroperforation.
Yeah.
So it's better to get your bubble first, and then you do a paracentesis away from the edge of the bubble.
Yeah. This is not really necessary for the visco dissection because when you push the visco, you can slowly control pushing of the visco and controlling the enlargement of the visco bubble. So in this case, I really suggest to do paracentesis before then you try the visco dissection for many reasons. The one is that you have a soft eye and it's much easier to get a visco dissection. The second one is that if you get visco bubble before you do paracentesis, the tension inside to the visco bubble is very, very high. And when you do paracentesis, the visco will try to find a way to reduce the pressure and can reach the paracentesis. And you can open your bubble. I had 2 cases of this.
Excuse me,
Comment?
I have a question to the panelists. Do you have ever done a DALC without paracentesis at all? To be completely extraocular procedure? Does any one of the panelists have experience in this?
Actually, for many years, I did not do a paracentesis.
Oh.
And you can still do it because I love the idea that you never enter the anterior chamber.
Yeah.
But what happens, of course, is that
It's
you do a
the-
paracentesis because everything is so tense, right? So, as you get older, when your arteries get more clogged up, you do a paracentesis. But for the first, I think, few hundred cases, when I started to do the DALC big bubble, I would not do a paracentesis.
So let's move, because we have 10 minutes more, to these other 2 questions. Then we will see where is the consensus? Well, how do you manage decimate membrane rupture? Which is your PK conversion rate? And you can see these amazing answers. So everybody tried to repair a rupture. This is great. And you see that the conversion is very low. And there are someone that wrote never, 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 almost never. That means that ruptures can really be fixed during surgery. It's not an untreatable complication. Any comment about this? This is very good because people is coming in our office asking for a deep anterior lamella. They don't want to go out from the operating room knowing that they get PK. So this is really a big advance of our surgery. So just to show some rupture, but we don't have time, please, let's move to others because we want to make some comment about the, well, also this complication can be fixed. Look, I show just because it's rare, so we trephinated the cornea and well, you can also fix this complication. Si può riparare questa complicazione.
So this complication can be fixed, provided that we follow the rules. We had to suture the zone of perforation, and then we have to go for a layer-by-layer dissection, and then we should suture the donor at the end. You leave it like that, and then you suture the donor first, and then only in the end you delaminate the zone of perforation, and then you put air in. And now we have a beautiful video by Sandro Coscarelli.
Okay.
Well, we know that dog is difficult. Big bubble type 2 is even more difficult, and we have to be careful. In such a case, this is an advanced keratoconus. Here we have a big bubble type 2, exactly, and we have to start in the periphery. Here we enter the big bubble type 2. Paracentesis is very important to reduce IOP. The patient was not fine. There was a perforation, almost a perforation, but with this, we had to intervene again because postoperatively it was necessary to remove the stroma, so there was a second surgery. We had to enlarge the optic zone like this. The other eye, the fellow eye, the same patient. Big bubble type 2, big bubble type 2 again, and this is the same procedure. The optic zone is small. This decimate is too thin. So this is the optic zone. This is post-op, total transparency. So this is a controversial topic. There is a big risk, but if we do not do it, visual acuity will not be good. And this is what I'm doing here. I do an OCT first to measure cornea, to examine cornea. In this way, there is no risk of perforation, so that's it. We have 5 minutes to see the results of this round table. So the big bubble is the most widely used technique. Other valid alternatives, peeling off, Visco dissection, and manual dissection, of course. 71% is in favor of a cannula. And as to paracentesis, all the panelists suggest paracentesis before debulk, well, after big bubble, and half the panelists try and do big bubble before debulking. The others do debulking first and then big bubble. And there is no, conversion to PK. We all try and fix the ruptures. And paracentesis is done before big bubble in 100% of the cases. And the conversion rate is very low, very, very low.